Hello everyone, and welcome to today's webinar, Trauma Verification's July Q&A Web Conference. Before we get started, I would like to go over a couple of housekeeping items. We recommend you using your phone to join this webinar for optimal sound quality. You can find the dial-in information in the audio section of the GoToWebinar control panel. If you experience any technical issues, such as lost audio during this webinar, please submit them into the questions pane and I will be notified and will work with you one-on-one to get it resolved. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you everyone for joining today's web conference. It's July 27, 2017. Just want to introduce our team. We have Tammy Morgan, who will not be with us today. However, we have myself and Rachel Sanchez, the site visit coordinator. Continuing education, for those of you who are new, to qualify for CE, you must attend at least 15 minutes of the education content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim CE. If you have any questions during the presentation, please feel free to email us at thecotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Understand the process and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your facility. So with that said, we're going to go ahead and get started. So for those who've not have not participated in our webinars before, please have a copy of your resources manual. If you don't have a hard copy, or you can certainly download a PDF copy from the website. If you are using an electronic version or a hard copy, make sure that you are also using the clarification document and the verification change log in conjunction with the manual. The clarification document, verification document updates are done on a monthly basis. I just released one a few weeks ago, and I'm going to be doing another one here shortly. These documents can be accessed through our VRC resources webpage, as you see here. And as previously stated, going forward, all changes to criteria will be published in the verification change log, and any criteria that require clarifications will be noted in the actual clarification document. The next few screens are just screenshots of what these documents look like. They're a little different from each other. The clarification document cannot be sorted. It's just a document in PDF format. The verification change log is an Excel format, so you can certainly filter and scroll and sort as you see fit. The recordings of today's webinars and past webinars are found on the ACS YouTube channel, and those are accessible on your page, and they will be found at the bottom of the page. So I would like to ask you to scroll, and we are looking to actually develop its own link in the near future. All questions are pulled directly from the questions submitted through the portal. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from ACS staff within a week after the webinar. And also, if your specific question as you submitted is not on the webinar, please note that that's probably because there's another question that's very similar to it, and I did display that question with the same response. Just a few announcements. The next verification Q&A webinar will be Friday, the deadline to submit questions will be Friday, August 11, 2017, and the actual webinar date will be Wednesday, August 30th, 2017. Our time slot will be from 12 to 1 Central Standard Time. And I'm going to go ahead and introduce Rachel now.
Good afternoon. The 2017 TQIP Annual Scientific Meeting and Training will be November 11th through the 13th. This year it will be held at the Hilton, Chicago. Registration will be open by mid-August. However, hotel reservations are open and we recommend reserving your room early. You'll find more information at the link listed. There will be plenty of a variety of pre-conference workshops in which you can sign up for. Registration is open for some of the workshops. You'll see some of them listed on the slide here, and you'll find more detailed listing at that link listed.
So this is Molly again. So I just want to jump in and just talk a little bit about the resources revision, and I do have another slide through the presentation. So again, for those of you that are new to our session, we do have the Stakeholder public comment website available, and that's going to be open for the rest of the year. It's going to be an ongoing process, and if anyone has any concerns about any of the standards that are currently in the manual, you certainly have the opportunity to provide us some comments on those, whether they need to be modified, they need to be retired, or if there are any new requirements that need to be added, or even if you think it needs to be clarified even further. And so this is kind of like the time to do that. We're looking at all chapters right now. The next couple of chapters that are under revision, and again, this can change, but right now we're looking at chapter 9 and chapter 10. Definitely pediatric surgery is our next one. And then the one following is chapter 15, registry and research. And again, this can certainly change going forward. That being, we can add more chapters to this or take away another chapter. But again, this is the time to go ahead and give us some comments on how you would like to see the next version of the resources manual going forward. I also want to let everyone know that we have a new link for frequently asked questions. We just put this up about a couple of months ago, and this will expand over time. Currently, I believe there are 12 questions. There's 12 Q&A questions on there, and they're pretty much contain those that are commonly asked over time. So again, we're going to go ahead and build on that. So for the time being, it's linked to the Trauma VRC FAQ page, as you see here. So to access the page, you're going to go to the VRC Standards FAQ. And what you're going to notice is that currently, because we don't have a whole lot of data, we do have a list that you're going to have to just scroll through the page. But in our next, or in the future rather, we're going to have the ability to do it by the level and by the category. So again, we have 12 now, and we're going to build on that. So I would like to ask you to go ahead and visit that frequently, just to see if there's any new updates. And I will definitely keep the participants during our webinars up to date on how that's going forward. Just want to remind everyone there is a tutorial for new trauma program managers wanting to have or know more information about our process and how that works and how that looks. And that is also on our webpage, as you see here at the bottom link. Go ahead and give this over to Rachel again for some scheduling reminders.
Okay, in regards to the site visit application, the application for your site visit must be received in our office 13 to 14 months before your visit. This not only gives you plenty of time to prepare for the visit and complete the online PRQ, but it also holds your spot for the visit. At this time, we are completely booked all the way through July 2018, and there are just a few more spots available for August 2018.
So there's a couple additional documents that need to be submitted with the application. As Rachel mentioned, the application has to be submitted approximately 15 months ahead of the time that you want the visit scheduled. In conjunction with that document, you also, for level 1 adult trauma centers and level 1 pediatric trauma centers, you must submit the orthopedic traumatologist leader form. If you've been through the cycle, say in 2014, and are now up for re-verification, you want to definitely check with Anita to find out if we have your OTL form on file. This way you don't have to complete another form. However, if there's been a change to your OTL leader, you definitely want to complete a new form. And again, if you have any questions whether or not we have that particular OTL leader on file, Anita can definitely check for you. You just send that to the COT-VRC at FACS link, and she'll go ahead and confirm that. The other thing you want to note on your application is the alternate pathway request for new applicants. If you've had someone at your facility go through the alternate pathway and they were approved previously, there's no need to provide us a copy of the CV. We do just want their name. However, but for new applicants, you want to go ahead and fill out that lower quadrant of the second page, so that way Rachel will follow up with you. Again, this is just a reiteration of what I just mentioned, that if you previously have completed a form, there's no need to submit another form. However, you do want to let Anita know, otherwise what's going to happen is she's going to go ahead and reach out to you and ask you for the form. So I'll definitely work with her on that to see if there is an opportunity to put something on the application to say that you have submitted one previously, or maybe your OTL leader's name on there. But again, you want to go ahead and confirm with Anita at the COT-VRC@facs.org whether or not she has a form on file for your particular trauma center. If you are part of a tandem adult level 1 and pediatric level 1 trauma center visits, whether it's being done at the same time or done maybe separately at different points during the year, again, you want to definitely check with Anita. You don't need to repeat the process, but we do need one official form on file. So you go ahead and send your questions to the COT-VRC box. Alternate pathway request, as I previously mentioned, if you have a new candidate or a new provider on your service who is not U.S. or Canadian boarded, basically those who did not train here in the U.S., they can definitely or go through the alternate pathway process. There's a couple of things that we'll need to get that process started, that being the applicant's name and their specialty, and a copy of their CV. That information will be reviewed by the subcommittee that specifically provides or specifically reviews those CVs, and they will definitely let Rachel know whether or not the candidate can go forward with the alternate pathway process. Again, there's more information about the alternate pathway criteria and process on the link you see here, which is under the site visit packet.
Okay, in regards to the pre-review questionnaire, online access, when we receive your application here in the office, you will receive an email receipt, and in that email receipt, the PRQ logins will be in the context of that email. So you'll want to hold on to that email. And then the online PRQ can be accessed at the link, and also a copy of the PRQ in Word can be downloaded from the link listed. So for the site visit application payment, we ask that you please do not submit payment with your application, because your center will be billed annually for a trauma quality program fee. And this fee, it does not include fees for the additional reviewers if needed. At the link below, there's a really great fee structure with the fees for the next 3 years. So we encourage you to view it. Okay, for scheduling the site visits, you should receive your site visit dates by 90 days before your scheduled visit, give or take. And ideally, all the visits will occur during your requested time frame. But I do want to explain that typically you'll receive your dates before this 90 days. It's the 90 days when you should have your confirmation email letter with all the reviewers listed on there. So when a lead reviewer is available for your site visit, I'll first contact the trauma program manager to confirm the dates prior to finalizing the visit. Site visit preparation with reviewers. Reviewers will book their own flights through the ACS travel agent, and they do this approximately 30 or sometimes 20 days prior to the visit. The hospital is responsible for the site reviewers' hotel accommodations as well as their ground transportation. The reviewer's contact information will be provided once the full team has been secured, approximately 90 days before the visit. And please be sure to contact the reviewers directly within 30 days of the site visit. And this is, just to email their hotel confirmations, get their flight itineraries, coordinate the ground transportation to and from the airport, and any other site visit logistics.
Now, Rachel, if they don't hear from the reviewers, would it be okay to contact you?
Yes, you can contact me, definitely. And I'll reach out to the reviewers.
Thank you. So I just want to talk a little bit about the focus review on-site preparation. I've had a lot of questions about this, and it's regarding our focus review agenda. I realized after several people have called in that there are some discrepancies in what is published right now, and Rachel and I will be working on that document next week. So we'll have that updated and available for folks to look at on the website and when Anita sends out materials. So basically a focus review will occur if a trauma center is undergoing verification or re-verification, and there are, if an on-site focus review will only occur if there are medical cases that need to be reviewed to address any of the deficiencies cited. So just want to make clear, because there is also by mail or by documentation, which is different. So the on-site focus review, which is a team that is on-site, is a one-day process. Initially, or ideally, one of the initial reviewers will return, possibly both, but generally one of the same reviewers will return. If Rachel's unable to schedule a second reviewer, you'll get a nurse reviewer as a second reviewer. We will require a corrective action plan approximately 30 days before the scheduled visit date. So we'll need the trauma center to provide information on the deficiencies and how they were addressed and how the weaknesses were or may be addressed. I realize, again, after discussion with some folks, that there are some weaknesses that may not be, the center may not be able to address, and we understand that. But you do want to make some concerted effort to address that weakness in the corrective action plan. The trauma center has the opportunity at this time to do a presentation on the corrective action, so they can definitely do that at the time of the focus review. It's not required, but if you have one and would like to do that, you certainly may. The review, again, it's done in actually it's done really a half a day, approximately 5 hours. So ideally what the majority of reviewers do is they will fly in the evening before the site visit and commence the review about 7 o'clock in the morning, unless there are some situations where flights are delayed, or for some reason some reviewers can do it the day of, and if they do decide to do that, what would happen is that review will probably happen in the afternoon. So, but ideally it's usually in the morning. But again, you'll hear from the ACS office or the site reviewers if that should change. During an on-site focus review, there is a chart review process. Again, that's the purpose for having an on-site review. So the charts that will be required are those that are currently outlined in the focus review agenda that has not changed. What is a little confusing to some folks is that it does say that we want the center to pull cases that reflect the changes made following the focus review. So you want to start when those changes were made and how and when it impacted your program. So Ideally, some centers start right off the bat after the exit interview. Some centers will wait until they get the report. In either case, that's fine. We just want to make sure that what the reviewers will be coming on site to review demonstrates or shows or displays what you have fixed. So what that really means is that you're not going to have the minimum charge that we've asked. Again, it's just the minimum. I know there's some categories that say 10, some say 30. You may not even have any categories in some of those or any charts in those categories. So just pull what you have available at that time. Closed meeting, there's going to be a closed meeting with the reviewers, just like there was at the initial visit. This is an opportunity, should there be any questions or clarifications that the reviewers have, it'll be done at that point in time. And then there's the exit interview. Again, that is going to be left up to the trauma center on who they want to attend. Again, that could just be a small group of folks, or it could be as many people as you like. So I'm going to just go ahead and introduce a couple of staffing updates we've had. For some centers out there are probably seeing emails from some new staff members, so I just wanted to just introduce these folks for you guys. So VRC staff are reports and standard questions for like resources questions. So that's going to be Megan Hudgens, which you're probably familiar with seeing her emails come through. We also have a new coordinator, which is Bhumi Parrish, trauma verification coordinator. She's new to our trauma program. I like to welcome her. So you may from time to time see emails coming from both these ladies. And the other person that's on my team is Kendra Marbley. So she's my trauma verification assistant, assisting with our program. So again, I just wanted to introduce these folks to you in case you see emails from them. It's not someone that's unknown, but they're part of my team. So a couple of things about clarification document updates. I just sent, as I mentioned, I sent an update a couple of weeks ago, and I just want to just run through those updates and changes and clarifications in this next couple of slides. One of the updates, I believe I covered this in last month's slide, but I'll go ahead and cover it again, is CME for ICU intensivists and hospitalists, since we were getting tons of questions about this. I am so happy to report that our chairs actually came through and provided some clarification on this. And again, let me just stress that our reviewers also get a copy of all our my updates, so they are aware of these changes that I'm going to be reporting on. So again, CME for ICU intensivists, if the intensivists are the primary physician responsible for the care of the patient while in the ICU, this being patient's care is transferred to them. They're no longer under the trauma surgeon or ICU team. They are required to maintain external CME and or through an IEP process. The VRC does not presently hold a requirement for hospitals to maintain CME. So there's another slide in here towards the end about CME for ICU physicians. And again, if the physician, if it's an ICU physician, they are required to maintain external CME and or through an IEP process at the facility. This is only related to intensivists and hospitalists. Universal screening, I've seen a couple of reports in the last year, not a couple, probably several reports on this. And again, we finally got the chair to add a threshold to this requirement because it was a little bit nebulous. Universal screening for all alcohol use must be performed for all injured patients and must be documented. That is the standard in the Orange Book. In the clarification document, this has now been revised to the following. All patients that meet NTDS trauma inclusion criteria, and this may again be a little different than what your state criteria is, with a hospital stay of greater than 24 hours, 80% must receive an SBR screening. So we've kind of lessened the threshold, we kind of lessened the burden, if you will, because before it was all trauma patients that were admitted. This is now giving you an 80% threshold to meet that requirement. So I just want to make sure that was clear. Here's a big one, research that's outsourced. We've seen this come in a few reports, and this is really, really important for you all. And I'm not going to read the entire research requirement that's in the resources manual. As you see here, it's on page 146 and 147. It's pretty extensive, so I will refer you to go ahead and read that in the manual. Basically, what the expectation is from the chair is the following. The statement implies that the trauma surgeons are actively involved in the creation of new knowledge and the research process. It is also implied that the research is done on site and not all sent out for performance by an outside group. It is also implied that the facility has provided support and resources other than simply paying for research output from an outside source. Therefore, it does not meet the intent of these requirements to simply pay to outsource research to an independent third party, not routinely, clinically associated with the facility. So what this means is that if you're outsourcing the research component of your level 1 trauma center, it is not acceptable. It has to be done at your facility by your trauma surgeons, by the specialists. That is required in pages 146 and 147. So go ahead and refer to those 2 pages. So I'm going to begin with general questions. So chart categories, as someone asked, this was a great question. I guess I never looked at it this way, but someone had asked if when you're looking at pulling cases for ISS greater than 9 and greater than 25, do the reviewers want to see those cases that begin at greater than 9, or is it those cases that begin at 10 or 25 or 26? So for site visit chart preparation, it will include charts with an ISS equal to and greater than 9 and an ISS equal to and greater than 25. For clarification regarding medical cases that have multiple injuries, this is another one. Do not duplicate that chart. Place the chart in one category and just tag it. You can put a yellow sticky on it, a green sticky, whatever kind of sticky you want on it. We do not want you to make copies of that chart. What may end up happening, and it has happened before, is that one or both reviewers will pick up the same chart because you've made duplicate copies and they're reporting on the same case. So again, if you have a case that has multiple injuries that covers several categories, just keep it in one pile and then just tag it. And again, if you are unable to provide the minimum number required for the cases, pull what you have available at the time. You may not have 10 of one specific criteria, so go ahead and just pull what you have available. Resources manual revisions. Someone had asked, and this is a good question, when will the revised verification standards be published? So I just want to let everyone know the plan for the revision process is still undergoing review. We started with one chapter, that being chapter 6, trauma surgery, as our pilot test. We are still working on that plan, and we have moved on to chapter 10. Right now it's with the work groups, and the intent is that once it goes through a series of approval through the ACS, then it will be published, and more information on how this will kind of come through will be related at a later date. For now, we're just kind of still working on the revision plan. Researchers manual, duplicate criteria deficiencies. Again, I think this has to do a lot with our revision process. The question was, why are there so many repetitive criterion deficiencies? It would be much more efficient to eliminate the duplicates. I would agree. However, I'm not sure if this person is referring to possibly, I don't know, it could be like peer review attendance where we have that covered in every single chapter that has to do with a specialist, and it's also captured in chapter 16. So it could very well be that, and the reason that we did that, and it was intentional, is because we wanted to ensure that trauma programs knew that those specific specialists were required to meet specific criteria, and it is going to be covered in multiple chapters. Chapter 16 is obviously the performance improvement patient safety chapter. So most of anything that has to do with PIP's process are going to be repeated in Chapter 16. So now that we are well underway with the revision process, we are definitely looking at the opportunity to not duplicate criteria and not have them overlap and make it more efficient going forward. And we'll be doing the same with the PRQ in the near future. Verification visits. When will the ACS begin an electronic verification? I wasn't really sure if this meant the actual application or an actual site visit process, so I covered a little bit of both here. So I did, for folks out there, an electronic consultation verification application is currently being programmed. It's not readily available, but it will be coming in the near future. This way, trauma centers will be able to apply through an online system. If the question is referring to an electronic process where an on-site visit will not be performed, that is not feasible with the current structure that we have set up now and how we do site visits. A lot has to do with legal and HIPAA restraints, and this will vary definitely between trauma centers. So right now, we've talked about it many times in our VRC meetings, and I'm sure it's going to be a topic of conversation going forward because there's a huge interest out there, but at the moment, it's just not feasible. TQIP benchmarking report, question from a level 3 trauma center. Their understanding is that we will need to provide a summary of our TQIP report during our ACS survey. Could you provide a detailed example of what this should look like? What would they like to know? It's a great question, and we will be educating our reviewers in the fall on how to review and incorporate TQIP into the site visit process. But for the time being, and this is true for any level, not just a level 3, hospitals are not required to receive a TQIP hospitals are not required to have received a TQIP benchmark report at the time of their verification visit. We ask that hospitals have their last TQIP report on hand, if they have one, to discuss with reviewers if they request it. TQIP reports are a good opportunity for hospitals to showcase their PI process. Hospitals are not being penalized or lauded for their TQIP results alone. Again, it's just an opportunity for them to look to see how the program uses or incorporates their TQIP report. TQIP staff provide a summary of the hospital's TQIP results to the reviewers along with an executive summary and explanation of how to interpret those results. Geriatric trauma activation. Does anyone have any activation criteria for geriatric trauma activation? Great question, and if anyone out there listening has any examples and would like to share that with other trauma program managers, you're more than welcome to submit that to me at the COTVRC@FACS. And if you allow, provide us permission, we will go ahead and share that information. But at the current time, we do not mandate geriatric specific criteria. However, if the center sees a high percentage of these patients, it would be expected that these, it would be the expectation that there are geriatric specific criteria and guidelines. Down at the bottom, there are some examples of what it may contain. Falls above ground level in age greater than 65, traumatic mechanism in a patient with a known bleeding disorder, or use of anticoagulant, antiplatelet medication. Question about tax ID codes. If you have a level 1 trauma center and 2 other hospitals that are non-trauma centers under the same tax ID code, would those 2 other facilities or hospitals have to abide by the level 1 trauma regulations? Great question. So our process, the ACS consultation verification process, only reviews individual trauma centers. It does not look at multiple facilities within the campus or that use the same tax ID. So if you have 3 hospitals that use the same tax ID, we're only going to verify or review, if you will, consultation visit, the one main facility where everything will be housed. Performance improvement projects. What are some PI projects that some level 3 hospitals are working on? Great question. Here are some examples. Non-surgical admit by having, non-surgicals, as you know, are huge for level 3s and possibly for some level 2s. So one of the examples would be non-surgical admits by having a well-defined and structured admission policy in evaluating those cases, what patients are admitted to the trauma service versus those admitted to medical hospitalist teams. Time of trauma consent to intermediate second-tier level patients. This is often ill-defined with wide gaps in trauma evaluation after moving to a hospital bed. Geriatric trauma patients, where the focus could be on patients with rib fractures, time to the operating room on fracture care, or pain management issues for those elderly patients. So again, you want to definitely look at your non-surgical admits and define what patients would be admitted to the trauma service, and are those being evaluated by the process. And you also want to look at what non-surgical patients would be admitted to the hospitalist or medicine. So you want to have a well-defined admitting policy for the trauma service for those patients. So those are some really good examples for level 3s, and it could be used for any trauma center actually. Post-site visit documentation. I wanted to talk a little bit about this. We had some instances where this kind of didn't get addressed. If during a site visit, whether it's a verification or re-verification site visit, the center is found to have deficiencies and the review team says it's okay to forward documentation to resolve or address that, once they leave the facility, I want to stress that the review team has a specific number of days to complete the report and submit that to the VRC office before they are, I don't want to use the word penalized, but basically get an email from Megan or Boomy to send us their report. So they do have a required set amount of days that they have to submit this. So if after a site visit you are told that you may submit documentation to address something that was found to be deficient, make sure you confirm the time frame to submit that documentation. So, so if they're telling you you need to submit it within 3 days because they have to submit this report in 5 days to the ACS office, just get the documentation to them within that time frame. If you think it's going to be delayed, you also want to communicate that with the reviewers, because once the review team submits the report to the VRC office, it is really at their discretion whether or not they will accept the documentation you submitted. Otherwise, you may have to wait until after the report has been released by myself to then address those deficiencies. Again, I want to stress the importance of, if you are being asked to do this, that you do email the review team, but also email the CLT office, or the VRC office for that matter, sorry, at the cltvrc@facs.org. We will ensure that the reviewers see the documentation and incorporate that into the report. There have been instances where the documentation has been provided to the reviewers, but has not made it to the report. So that is a huge conflict. So I just want to make sure that I did stress the importance of also copying the VRC team on that communication, so that way we can follow through with that. I'm going to move on to CD-related questions. I had a question about CD 2-8. Activation time is when trauma physician has been notified, or when trauma physician return call, or when physician actually sees patient in ED. If trauma physician is called but no documentation on patient seen by trauma physician in ED, is it still level 3 response activation? So a lot of questions in this one specific one. So hopefully the person who submitted this question, I've answered your question in my response. If not, please follow up with me. So the time for the provider, that being the trauma surgeon, to respond is when the request is made, that being called or paged, or however that communication is sent to the surgeon, and ends when the provider responds in person to bedside. So it's not a phone call, you know, they're at home and they're in a phone call and they're calling in. They have to come in if it's a level 1 or 2, even if your level 3 calls for that. Again, that's going to be policy driven for your level 3 response if that's your consult tier. Again, if by level 3 response activation, I'm assuming that to be your consultation tier, and if so, the institution will define the types of injuries for when the trauma surgeon is expected to respond. This must be documented and reviewed through your PI process. If you have a lot of instances where response times are not documented, this may result in a CD or a weakness. So I just want to make sure, because that is a lack of documentation, and if it's noted in all the cases that the reviewers are seeing, it's going to be cited as a deficiency, or they may cite it as a weakness. It just depends on how often it's being seen in your case review process. Trauma surgeon response. For level 1 trauma center, do you have to have 24/7 in-house coverage for trauma surgeons? The manual does not state that trauma surgeons must be in-house. With this said, for the highest level of activation, because this is a level 1 trauma center, the response threshold, the response threshold is 15 minutes for the attending trauma surgeon to respond and be present at bedside from the time of notification. Again, if they're being called for an activation, they have to respond in person, and it's 15 minutes. So the ideal method for these folks or these trauma surgeons to get there is by having them in-house. There's no requirement on this, but they have 15 minutes to get there. So ideally, the best method would be to have the trauma surgeons in-house. Trauma surgeons dedicated. We have a level 2 trauma center. Our town has a second smaller hospital that has no trauma center designation, nor is it ACS or state. Can our primary on-call trauma surgeon also be primary general call for this smaller hospital at the same time? Orange Book only refers to dedicated to a single trauma center. The second hospital has no trauma center designation. Great question. It does come up often, and it's not ideal. That is not an acceptable practice. So the trauma surgeon who is the primary trauma surgeon who's on call must be dedicated to the one trauma center at all times. So they cannot cover 2 trauma centers while they're the primary at one and having to be the second in another. That is just not gonna be acceptable by any means. It'll be cited as a deficiency. Neurosurgeon response. Regs speak to the facility setting up a 30-minute response time for certain ortho or neural diagnoses. Is this sufficient for neural, large traumatic, hematoma resulting in greater than 5 millimeter shaft and or compression? And it goes on to a couple of other injuries. So what I want to say about this is the intent is that the trauma medical director and the liaison for ortho or neuro develop guidelines at that institution for which types of critical and complex injuries the neurosurgeon and or orthopedic surgeon will respond to. So ACS is not going to restrict them or guide them on what those are, but the trauma medical director and the liaison have to develop guidelines for which types of critical and complex injuries the neurosurgeon and or orthopedic surgeon are going to respond to within 30 minutes. With that said, if they send the PAs or the APPs to respond for those, there must be guidelines that state or speak to those injuries that the APPs are going to respond to, and there has to be clear documentation that there was a discussion with the specific surgeon specialist on the plan of care for that patient. So we've covered this on multiple webinars, so I just wanted to go ahead and clarify that even further. Question about does the 30-minute OR availability refer to having an operating room, an open room, or a room that is fully OR ready? Good question, and this is a level 3 trauma center. So in level 3 trauma centers, an operating room must be adequately staffed and available within 30 minutes. This means that there must be an operating room available and staff to prepare the room and patients while waiting for the anesthesiologist or CRNA were permitted by state laws. There are some states that permit their CRNAs to do this, to arrive. Is there an acceptable threshold for meeting the 30-minute OR time, such as the 80% surgeon timeliness for trauma team activations? There is not. Another question comes up often. We do not have a threshold for meeting that 30-minute mark. If during a site visit it's found that there were delays and it was not picked up through the PIPS process and there was an inaction or review through your PIPS process, it would be cited as a deficiency. So again, If during a site visit it's found that there were delays and was not picked up through the PIPS process, it would be cited as a deficiency. So if you are seeing some delays, you want to make sure you're reviewing that and there's a corrective action plan in place for that, and that you're tracking that, trending that, and able to demonstrate to the reviewers that you are in compliance with that when you have identified an issue. Operating room response regarding CD 1118, what is considered timely for starting operations. I was not entirely clear on this question, so again, the person who submitted this question, if I did not answer it properly, please follow up with me. The intent is that the OR room and staff are ready to go at the 30-minute mark. My concern is that there may be some issues at the center with having the room and staff ready at the start time. If this is the case, the program must identify those issues by continuously monitoring the start time through the PIPS process to ensure that there are no adverse outcomes due to delays. Again, if there are issues being identified with starting on time, whatever that is at your institution, you definitely want to have a plan in place for catching that and reviewing those delays. Question about the registrar. What are the staffing guidelines after the first 500, 750 cases? Had another question. Volume is 700 and there is one registrar to complete all tasks. When would you recommend increasing staff? These are all great questions. And again, I will say this at this point that for this specific requirement, I know there's been a lot of discussion and clarification around this. I will strongly encourage you to go visit the Stakeholder website and provide us some commentary on this and support whether or not this should be edited further or changed, because this is definitely going to be an area where we're going to look at in the next few months. Actually, for the revision process, we're going to focus on Chapter 15, the registry. So in response to these questions, right now, the requirement is that there is one FTE registrar for every 500, 750 trauma patients admitted to be entered into the registry. If the center exceeds this threshold, the expectation by the reviewers is that there is another FTE to manage the overflow. So for example, if the trauma center admits 2,300 trauma patients, the expectation would be that there are a total of 3.5 FTEs. So, and it may be even more than this, because it's not just about the registry. The registrar is also doing other duties, running reports, validating the registry, ensuring that it's in compliance. So there's more to this than just this, and that's why I'm encouraging people to go ahead and visit the comment website and provide us some more information on this, so that way we can definitely improve the standard, if you will. Question about mortality review. Clarification document, the new category, clarification. The new categories of mortality review are mortality without opportunity for improvement and mortality with opportunity. I'm not really sure if that's noted somewhere other than in my clarification document, but I did update that a while back, and there are 3 categories to this, and that is mortality with opportunity for improvement, mortality without opportunity for improvement, and unanticipated mortality with opportunity for improvement. So there's 3 categories. I believe there may be a few courses out there that are capturing 2, but it is 3 for verification purposes. So I just want to make sure that was clear. Question about injury prevention. What are other level 3 hospitals doing for injury prevention in the community? So what I've done here, I've just kind of did a little checklist. So what you want to do is develop intervention strategies, and that could be from prevention coalitions by working with other community partners such as the highway safety, EMS, senior centers, other trauma centers, to develop programs and train individuals. You also want to know if there programs already established in your community to participate in, like such an Safe Kids Think First. You don't want to reinvent the wheel. You want to kind of see what's out there and maybe just join those efforts. You want to implement the program. Whatever you're implementing as your injury prevention, make it where it's implemented with your research components. Create a mechanism to provide feedback to agency partners and the community on the success of those efforts. Did your prevention efforts change behavior? You want to track things like that. You want to monitor and support those kind of things. Are you seeing trends in your registry data that are part of the state registry? So you want to evaluate those and revise those results as you see fit. You also want to reevaluate and revise your efforts if the outcome is not, if you don't see any positive outcomes on that. Again, you want to consider publishing results, make it part of your research component. And you also want to measure those outcomes, as I stated before. So just a couple of highlights on injury prevention. Alcohol screening, just a few slides on this. I understand that there have been changes to the SBIRT. Can you share the changes? As I previously stated, the change is that we've added a threshold. Nothing has changed on screening those patients, so we just added a threshold, just making it less burdensome on the trauma center. So the clarification again is all patients that meet NCDS trauma inclusion criteria with a hospital stay of greater than 24 hours, 80% of those must have received an SBIRT screening. So again, we've just kind of put a threshold to that. Just a couple more questions on this. Universal screening for alcohol use must be performed for all injured patients and must be documented. Can you comment on the necessity of this as we get continual resistance to do drug and alcohol screening on trauma other than motor vehicle accident drivers? So basically, it is recognized that alcohol is a significant risk factor for trauma, and the effects of alcohol use have been well documented in trauma literature. There's a ton of literature out there on the impact of alcohol screening or the risk of alcohol. So as of now, it is an ACS requirement for verification that all trauma centers screen for alcohol use on patients that meet the ACS registry inclusion criteria. Again, for those that have a stay of greater than 24 hours, in which 80% must receive SBIRT. And what I want to say is that we are not determining the screening tool. We provide some examples of what can be used, but the trauma center certainly can use whatever screening tool they wish, even if it includes blood screening, that's also acceptable. For alcohol screening, we use blood alcohol to screen again, and social services documents the counseling is sufficient. That is an acceptable process and acceptable practice. And to clarify, the program must document the screening process, and as well as the social worker or the social services that are providing the counseling, that must also be documented as well. So in both instances, it has to be documented. Research requirements. Do all research papers need to be PubMed searchable as of 30 days prior to a site visit, i.e. multi-center trial firm, AAST, East, etc.? Great question. Manuscripts that have been accepted but not yet published or searchable through PubMed Central, which is their searchable database, will meet the research requirement. With this said, if it's not yet published and it's not yet in the searchable PubMed Central, the trauma program must provide documentation that says or demonstrates the manuscript has been accepted. So there has to be some documentation that it has been accepted. And manuscripts that are part of a multi-trauma center trial are also acceptable. CME, state requirement versus verification. I thought this was a great slide to bring in. In this particular scenario, the state requires an average of 8 trauma CME per year over a 3-year period, which is a total of 24. As we go toward our consultative visit, is it 16 this year and 8 the other years for a total of 32 in 3 years period? What do we need to have? So this is a great question in the scenario. And as a new trauma center for ACS, this trauma center will be required to follow their state requirement because it exceeds those of the ACS. If it were the other way around, where ACS holds the trauma center to a higher standard, then the trauma center will be required to comply with the ACS. For example, in this particular trauma center, For new centers seeking a consultation, visit, or verification, all providers must have 1 year, 16 hours minimum of trauma-related CME. So this particular trauma center, their state requires them, holds them to a higher standard in this instance because they're asking for 8 over the last 8 CMEs annually over the course of 3 years, where for a new trauma center coming on to ACS, we're only asking for 16 hours for the year that they're going to be verified. So it's a little different. So I thought that was a great question. Trauma versus critical care. This is regarding the new list from ACS, which states if the intensivists are primary physicians responsible for the care of patients while in the ICU, where the patient care is transferred to them, they are required to maintain external CME or through an IEP process. The VRC does not presently hold a requirement for hospitalists to maintain CME. Does the CME have to be strictly trauma or trauma critical care CME? Can it be just critical care CME to count? Great question, and it could be either or both. As a point of reference, critical care CMEs are equivalent to trauma CME, and this is also in the clarification document that critical care CME is acceptable as trauma CME. Number of trauma-related CME. For CME, the regs speak to the liaisons having 16 hours, but elsewhere it also talks to all the neurosurgeons and other specialists having 16 hours of trauma CME. Please clarify. Again, this has been covered in several other webinars. The trauma medical director and liaisons must have a total of 48 hours of external trauma-related CME over a period of 3 years leading up to the site visit. Again, these are for re-verification visits. This can be obtained by having the providers obtain 16 hours of CME each year. So each year they can have 16 hours leading up to the re-verification visit. It'll be 48 hours. For non-liaisons, that being trauma service, neurosurgeons, orthopedic, emergency medicine, ICU, they may use a combination of external and or internal education to meet the CME requirement. And again, this must be obtained as 48 hours over a course of 3 years, 16 hours annually of CME each year. CME, ICU, is it still required that all physicians who take care of trauma patients in the ICU have 48 hours of trauma related? If yes, do they have to be external, internal, or both? This is not inferring that they're intensivists or hospitalists. This is just for the ICU physicians. So the ICU liaison has to have 48 hours of external trauma related over 3 years. Non-liaisons for ICU, again, not intensivists and not hospitalists, may use a combination of external and or IEP to meet the CME requirements. This must also be obtained as 48 hours over a period of 3 years, 16 hours annually. Internal education process. Does the yearly 16 hours need to be offered to every non-liaison or based on specific recommendations from the PIP? It's the latter. So IEP does not need to be offered to every non-liaison provider. The non-liaison providers may use a combination, as I've stated before, of external and or IEP to meet the CME requirement. If the trauma program is going to use the IEP process, it is recommended that the content be based on issues identified through the PIPS process. There are examples of internal education, CME, other topics actually, as noted in the resource manual on page 47, 51, 57, and 64. So that concludes our webinar for today. I want to thank everyone for joining us.
Great. Thank you, Molly. Thank you, trauma verification staff, and thank you everyone for attending today's webinar, Trauma Verification's July Q&A web conference. If you have any other questions, please contact COTVRC@facs.org. That is COTVRC@facs.org. On behalf of Trauma Verification team and our presenters, thank you for joining us today and have a great rest of the day.